When we first started using SITA testing, sort of the general consensus was SITA standard was the test to use. It was more accurate, it was more reliable, it was more consistent from test to test. And while Faster was faster, we were all sort of leaning towards SITA standard. One of the problems was with the old GPA, you couldn't mix and match tests. So if you started a patient on SITA standard, you really had to keep them at a SITA standard. And even as they were getting older and maybe it was becoming harder for them to do the test, you still couldn't make that switch. Now with the GPA on the HFA3, you can mix SITA standard, SITA fast, and even SITA faster. And so you have a patient who maybe you started on SITA standard and you're reluctant to change strategies, you don't have to have that worry anymore. So when HFA3 first came out, really the changes that I saw compared to the previous units were mostly in kind of workflow, so it was easier for technicians. There was the liquid lens, which reduced errors for the trial lens. There were the instructions that the technician could see right on the screen, so you're getting more uniform administration of the test, which is always really good. But now with the HFA3, we have SITA Faster, and nobody likes to do visual fields. The technicians don't like to be in a dark room with a patient. The patient doesn't like to do a visual field. And so anything that we can do to make it faster for the patient, easier for the patient, we feel like we're going to get better data. So now you can take a 24-2 and in a normal patient do it in a minute and a half. In a patient with glaucoma, you're going to cut your time down about 50% from SITA standard. That's just going to make for a good day for everybody. So patients are going to be happier, doctors are going to be happier. We don't lose any reliability or any accuracy by going to the SITA Faster, and it's just going to make everybody's day better. So for years, we've looked just at nerve fiber layer and then 24-2 visual fields. And in the last 5 years or so with Don Hood's work looking at the importance of the macula in glaucoma, it's really come to light that there are some glaucoma patients who their earliest visual field defects are in the central 10 degrees. And with a 24-2 sampling size, we just don't really dig down into that central 10 degrees. So what we sort of started doing was doing a 24-2 and a 10-2, which slows things down and makes it miserable for the patient. So with the 24-2C, they've incorporated 5 central points superiorly and 5 central points inferiorly. So we sort of get the best of both worlds. We don't have to do 2 visual field tests, but we can get the 24-2, so we're not missing any of the peripheral visual field loss, but we get some of those high importance points in the central 10 degrees.